Hello everyone. Today we are going to discuss another set of one-liners and MCQ in pediatrics. To start with, which one is known as fifth disease? Is it Rogeola infantum, erythema infectiosum, SSSS or staphylococcal scarlet skin syndrome or scarlet fever? Which one is known as your fifth disease? The answer is erythema infectiosum. To recall, which one is known as first disease? It is the measles. Measles is caused the first disease. Second disease, scarlet fever. Third disease, it's rubella or otherwise known as German measles, that is known as third disease. Fourth disease is your Philatov-Duke's disease. It is no more used nowadays, but literature says it is the fourth disease. Fifth disease, it is erythema infectiosum. It is caused by human parvovirus B19. Similarly, sixth disease is your Rogeola infantum or subitum. It is caused by HSV6 or human herpes virus 6. So we have to know that fifth disease, it is caused by parvovirus B19 and it is known as your erythema infectiosum. Next, which glycogen storage disease is associated with hemolytic anemia? Hemolytic anemia is associated with which variety of subtype of your glycogen storage disease? Is it type 2 or Pompe, type 4 or Anderson, or type 6 or Hart, or type 7 or Tarvey? The answer is, it is type 7 or Tarvey. This type 7 variety is associated with your hemolytic anemia. Some extra MCQs related to your glycogen storage disease. Second wind phenomenon is associated with which variety of glycogen storage disease? It is Mark-Adams disease. What do we mean by second wind phenomenon? Second wind phenomenon is a sudden decrease in heart rate and an improved exercise intolerance. Exercise tolerance occurring after few minutes of exercise. That is your second wind phenomenon. That is classically associated with your Mark-Adams disease. Similarly, cirrhosis of liver and early death is associated with your Anderson disease or branching enzyme. That the deficiency in your branching enzyme. Similarly, cardiomegaly. Which variety of glycogen storage disease is associated with cardiomegaly? It is type 2 or your Pompe's disease. Similarly, in which case you will get increased uric acid level? It is type 1 or von Ginger's disease. Similarly, cramps and myoglobinuria will get with your Mark-Adams disease. So, Mark-Adams disease is associated with your classical second wind phenomenon and myoglobinuria. This we have to remember. We can get a MCQ in our exam. Next, 18-month boy presented with short stature, constipation and lethargy. On examination, umbilical hernia, palpable goitre present. Lab finding shows low T4 and elevated TSS. What is the diagnosis? Looking at the question, just looking at the some important points like your short stature, constipation and lethargy, we know that this is a case of hypothyroidism, congenital hypothyroidism. Umbilical hernia is there, and what is the clue? Then and laboratory finding, we are getting low T4 and elevated TSS. That means hypothyroidism is confirmed. Then what is the cause? Is it thyroid dysgenesis or thyroid dysharmonogenesis or maternal TSH receptor blocking antibody is the cause or central hypothyroidism? Here what we can easily miss is your palpable goitre. So if goitre is there, then this is something other than what we think commonly, that is thyroid dysgenesis. It is not thyroid dysgenesis, rather it is thyroid dysharmonogenesis. So if otherwise it is fitting to thyroid dysgenesis. Suppose goitre is not there in the question, then answer is thyroid dysgenesis. As because goitre is there, so the answer is thyroid dysharmonogenesis. So answer is B, that is thyroid dysharmonogenesis. Next, 6-month-old failure to thrive baby is having posterior embyotoxon and butterfly shaped vertebra. Butterfly shaped vertebra, it is mentioned means we know the answer. Which of the following heart disease, but question is something different. Which of the following heart disease, heart defect is commonly associated with with this disease. We know butterfly shaped vertebra is associated with your Alagille syndrome. Then the question is, which heart disease associated with your Alagille syndrome? Is it mitral stenosis, TOF, peripheral pulmonary stenosis, or coarctation of aorta? The answer is peripheral pulmonary stenosis. Then something to know about your Alagille syndrome, we can get this butterfly shaped vertebra. This is the butterfly. Then we can get the butterfly shaped vertebra in Alagille syndrome. We can get triangular faces, your deep set ear, eyes, prominent forehead, pointed chin. We can get cholestatic jaundice. We can get peripheral pulmonary stenosis, and in eye examination we will get posterior embyotoxon. So this we have to remember. As Alagille syndrome, we can get all these findings. And the classical heart disease which we are getting in Alagille syndrome is your peripheral pulmonary stenosis. Next, 1-month-old male baby admitted to NICU for nonbilious vomiting. Nonbilious vomiting and visible gastric peristalsis. We know the answer. What is the disease? But question is, electrolyte imbalance most commonly seen is which electrolyte among these four, which electrolyte imbalance we are getting commonly in this disease? The disease is CHPS, congenital hypertrophic pylori stenosis. Then what the electrolyte imbalance we are getting? Is it hypokalemic hypernatremic metabolic alkalosis, or hypokalemic hypochloremic metabolic alkalosis, or hypokalemic hyponatremic metabolic acidosis, or hypokalemic hypochloremic metabolic acidosis? So the answer is B, that is hypokalemic hypochloremic metabolic alkalosis. This we have to remember. We can get paradoxical aciduria, that is different, but here we are getting hypokalemic hypochloremic metabolic alkalosis. Then something about CHPS. This is that olive shaped mark. What we are getting in case of this visible peristalsis, olive shaped mark we will easily get in case of CHPS. There's something about CHPS. This is the mnemonic of pyloric stenosis, pyloric, P-Y-L-O-R-I-C. P for peristalsis, which is visible, Y for yuck, nonbilious vomiting, L for lump on the left abdomen, O for olive mass, that is donut sign, R for Ramstead operation, which is the operation of choice, then I for imbalance of electrolyte, that is hypokalemic, hypochloremic metabolic alkalosis, and C is the circular muscles easily get affected in CHPS. Next, a newborn has bilateral cataract, microphthalmia, IUGR, hemorrhagic skin lesions scattered throughout the body, and a harsh systolic murmur at left lower sternal border. Then what is the diagnosis? Left sternal border, what is the diagnosis? This newborn is having bilateral cataract, microphthalmia, IUGR. This means we are getting a case of torch infection. Then which torch infection? In which case we will get bilateral cataract, microphthalmia, and hemorrhagic skin lesions. Then and also one murmur, systolic murmur. Then diagnosis, which one is true? Is it congenital rubella, syphilis, toxo, or CMV? The answer is congenital rubella syndrome. Then classical triad of rubella, that is cataract, cardiac abnormality, and deafness, that is sensorineural deafness. Cataract, bilateral cataract. The heart defect which we are getting is your PDA, and we can get microcephaly, other things, that hepatosplenomegaly, jaundice, meningoencephalitis, and profound mental retardation we can get in congenital rubella syndrome. Next question: a neonate has rudimentary digits, cortical atrophy, cerebellar hypoplasia, IUGR, and scattered skin lesions on limbs. The most probable diagnosis is rudimentary disease and cortical atrophy. We have to remember which among the following is the most probable diagnosis. Is it syphilis, varicella, herpes, or congenital lupus? The answer is congenital varicella. This is the typical picture that we have to remember. The maternal varicella, within the first 20 weeks, there is a chance of fetal varicella syndrome. What are the skin things? What are the findings we can get? We can get skin scarring. You can get eye defect, limb hypoplasia, prematurity and low birth weight, cortical atrophy, early death, and poor sphincter control. This is the typical limb abnormality and scattered skin lesion which we will get in case of scarring, skin scarring. Limb hypoplasia will get in congenital varicella syndrome. This picture we have to remember. Next, which one is true about rheumatic fever? There are four options. Chorea and arthritis coexist. As we know, chorea is late finding, arthritis is early finding. So we may not get chorea and arthritis at a time. Second, subcutaneous nodule are tender. Is it true or false? We know subcutaneous nodules are non-tender, so it is false. Third, erythema multiforme is a major criteria. We know that erythema multiforme, it is not erythema multiforme, rather it is erythema marginatum, which is a major criteria. So this is also false. So A, B, C, all are false. Then third, last one, ASO titer is normal in rheumatic chorea. We know rheumatic chorea we are getting as a late finding, late picture. So by the time chorea presents, your ASO titer will be normal. So this is the true thing about your rheumatic fever. The fourth one, that is ASO titer is normal in rheumatic chorea. ASO titer is normal in rheumatic chorea. Then just to recall, major criteria: carditis, polyarthritis, erythema marginatum, subcutaneous nodule, and chorea. Minor criteria: arthralgia, fever, elevated acute phase reactants like your ESR, CRP, and prolonged pair interval. These are the major and minor criteria, and along with that, evidence of a recent streptococcal infection has to be there to say this is a case of acute rheumatic fever. Next, Koch's criteria is used for diagnosis of what? This is a bit difficult, but we have to know, we have to remember, we may get one MCQ in exam. So Koch's criteria is used for your septic arthritis. Septic arthritis, what are the 4 criteria? It is the fever more than 38.5 degree Fahrenheit Celsius, unable to bear joint. Then third is ESR more than 40 and WBC count more than 12,000. These are the 4 criteria which, when all the 4 are there, then probability of septic arthritis is around 99.6%. Another, they are telling, if you are CRP, then the probability of getting septic arthritis is even more. Though not 100%, but it is more than this 99.6%. So we can add that. So we can know that Koch's criteria is used to diagnose your septic arthritis. Next, most common cause of communicating hydrocephalus. If you see the communicating hydrocephalus, we know that aqueduct of Sylvius, that is your whatever. Then what is the most common cause of communicating hydrocephalus? This is the subarachnoid hemorrhage. Most common cause of non-communicating hydrocephalus is your aqueductal stenosis or aqueductal gliosis, what we know. But if the question is bit different, that is most common cause of communicating hydrocephalus, then this is not aqueductal stenosis, rather it is subarachnoid hemorrhage. We can get some confusing questions, some confusing question where we think that the answer is this, but it is not that. Like this, if you see, then suddenly somebody can write that it is the aqueductal stenosis the answer, but it is not. It is, if communicating hydrocephalus is their question, then we have to answer that subarachnoid hemorrhage is the cause. If non-communicating hydrocephalus cause they are asking, their answer is aqueductal stenosis. Thank you. Please like and share this channel and subscribe to my channel. Thank you.